Good morning in America and good evening in India. Welcome to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Fuster Hospital in New York City. My name is Pedro Moreno. I will be your moderator today. We would love to hear from you, so please send us your questions directly on the website or on YouTube. And remember, you can review all our previous Structural Heart Life cases on ccclifecases.org. And now let me transfer you directly to the cath lab for a very interesting case.
All right, good morning, Pedro, and we thank our worldwide viewers, global audience, for continue to encourage us, bring the latest in all the fields of interventions, whether it's a coronary, structural, or and peripheral, and along with now the imaging and the microvasculature. So with that note, basically introduce our fellows. My associates, they're all the same, with Gilbert Tang, surgeon, and Dr. Keeney, Dr. Khera, and we are two fellows, Santosh and Maria Elena. We are actually 4 structural fellows. So whether they are too many or too little, we have to find out based on how busy they are on that week. But yes, knowing the structural require a lot of attention, pre and post of the patient care is very important. What we do in the lab is probably about 25%, 75% is the pre and post, but they are doing a great job. With that note, we showing a very interesting case, which actually we showed one in the beginning of the year, and now display here all our faculty. Disclosures, as you can see, all of us the same way, and Dr. Lerakas on the echo, and our anesthetist is Benjamin Salter. So with that note, today we are going to show the mitral valve-in-valve replacement transcatheter using 26 millimeter SAPIEN-3 Ultra Resilia for failed 25 millimeter Carpentier-Edward Magna Ease surgical valve with a balloon valve fracture, and we'll go through step by step. This is the patient, 73-year-old, our episode number 74, has a heart failure symptoms with edema, and patient had both mitral and aortic valve replacement in 2019. And clearly now has some degeneration. Aortic valve is okay, it's the mitral, and patient has been on Warfarin, and of course is from overall point of view, patient, the BS age high, good medical therapy, non-obstructive CAD, and echo showed predominantly mitral stenosis. So degeneration is more stenosis than regurgitation. So rather than I just say with a good LV, and we probably should be able to see live by Lerakas. Lerakas, maybe you can show. Yes. Go to the live echo, please.
Yes, thank you, Dr. Sharma. Good morning from New York. I'm here with our structural imaging fellow, Dr. Alizande, and our exceptional sonographer, Hafiz. As you can see here, 4-chamber view, mid-esophageal, normal LV function, good. Both dilated atria and mild dilated RV with mild decreased function. Left atrial appendage is clean, little bit smoke, but no thrombus. This is a post-tricuspid valve repair. As you can see, minimal tricuspid regurgitation. The leaflets open well. Mild pulmonary regurgitation. This is the aortic valve, bioprosthetic valve. As you can see, the leaflets are mildly thickened, but they open well. Mild aortic regurgitation, valvular. Small valve. The peak gradient is 17 and mean gradient of 9. This is also the LVOT gradient for us to know. This is a bicommissural view of the mitral valve. As you can see, the two leaflets, as you will see in 3D, they don't move at all. Mild to moderate mitral regurgitation, but as per Dr. Sharma said, mostly stenosis than regurgitation. This is a 3D image. As you can see, the two leaflets of the bioprosthetic mitral valve, they're not open at all. Only one leaflet is opening. This is a true view, demonstrating very nicely the severe stenosis of the bioprosthetic valve. This is from both the left atrium in your left and from the left ventricle in your right. As you can see, the two leaflets don't open at all. Mild to moderate mitral regurgitation on 3D image, no paravalvular regurgitation. The peak gradient is 20 and the mean gradient is 10, as you can get by echo. The aortomitral angle is 120. So it's a good case for valve to fix the bioprosthetic mitral stenosis. And this is the bicaval view showing the atrial septum. Thank you very much.
Yeah, so actually for you as well as for Gilbert, the question is, patient has a good aortic valve, 6-7 years ago was done, tricuspid is good, why mitral degenerated?
Well, I think what happens is that there's a high pressure environment, right, for mitral versus aortic, number one. And, young patient, he was very young when 2019, when he had the first bioprosthetic mitral valve replacement. There's some people who actually argue to put a mechanical mitral valve in there so you don't have degeneration. And we know that this is the trade-off, that you don't have to be on warfarin for life, but then you will have degeneration. And the younger you are for mitral, the earlier degenerate. So this is not entirely surprising. I mean, it's a little bit on the shorter side because it was 19, now it's 25, 6 years. But I think that's something that the patient should be aware of when they had the initial surgery.
So the leaflets didn't fail with calcification, they failed with thickening. So that tells me there's probably some subclinical halt that led to thickening and degeneration. More commonly happens in slow flow states on the mitral side than on the aortic side. So this is probably halt related rather than, and halt can happen in surgical. I know the data is from TAVR valves, but it can really happen in surgical.
No, it happens in both valves, you're absolutely right. But it's underdiagnosed, right?
Underdiagnosed, yeah.
But this case actually initially was, advantage was that will not be on warfarin, but then develop fibrillation and is on warfarin. So the halt should be lower if you're taking the oral anticoagulation, which this patient has been taking it, not the DOACs, but he has been on warfarin.
The other trend has changed, at least in surgeries, that we tend to like to put porcine mitral prosthesis rather than bovine, because bovine, this is the stenosis, is the mechanism of failure with bovine tissue, and porcine actually the failure is more regurgitation. And also the leaflets are thinner and also shorter. So from a valve-in-valve standpoint, the LVOT obstruction risk is actually lower with the porcine surgical valve.
Okay.
So in our center, we tend to like to use a porcine surgical valve for mitral replacement than a bovine.
Okay. This is the CT angio. Any comments on it?
No, I think the one thing that you know is to use the mini bypass valve-in-valve app, and you can see a 25 surgical valve is only 23 internal diameter. So that's pretty small for this patient with a BSA over 2 point something, right?
Yeah.
So, but of course, at the time of the surgery, you cannot put a too big a valve because you can risk AV groove injury. So this is what they could do given the tissue that they deal with. But now with the valve failed, the key is that can we put a larger transcatheter valve to avoid functional mitral stenosis. I think this is the crux of this case discussion, and that's why we choose this case. You can see the new LVOT is around 180 millimeters square. I don't know if Sam got a chance to measure it on echo. We usually like to correlate. It's not bad, but we do have to watch. And I think, but with the fracture, it should be fine. We'll keep an eye on it.
Now, what is the sweet spot in terms of the number of the new LVOT?
Different people and different devices say, there was about 200 and 150, so somewhere around there. So we'll, usually it's less than, it's bigger than you think actually.
So I think with that capacious angulation and a neo LVOT of 180, I feel really safe. We won't have any LVOT obstruction.
Yeah. And we're doing fracture as well, right? So.
Okay, very good. So this is the app which you talked about.
Yeah.
That we are going to put a SAPIEN 26 millimeter.
Yeah.
And anything unusual we need to worry about here, right?
So this is what I meant by, if you look at the valve picture, look at the bottom right corner of the fore panel. Yeah. See how the leaflet goes all the way to the commissural post? In porcine valve, it doesn't typically do that because the porcine valve is made of real pig heart valve. So they actually will be a little bit less. But obviously, that's why people do leaflet modification if they're concerned. So that's an important point for the audience to know.
Okay. So this basically summary of the case. Now patient was considered as a high risk because of the morbid obesity and poor functional status. And now we are doing a valve-in-valve TMVR with the right percutaneous femoral vein access using 26 millimeter SAPIEN-3 Ultra Resilia plus 2 cc in a degenerated 25 millimeter valve. Now, we're also going to do a true balloon valve fracture using 25 millimeter.
We'll use 26 actually.
26, okay. Yeah. All right, 26. Anu, where are we now?
Now we have done the Transseptal and
can we show the live images, both fluoro echo and please?
Yep.
Yeah, so we can see that.
Can you show echo as well, please? Yeah, thank
Before
you.
we did the puncture on the echo, yeah. So if you see where the mitral valve is, usually you have to be right there, so your trajectory will be fine to enter into the mitral valve. The other way they measure is like a one SAPIEN valve, the distance between the prosthetic surgical valve and where your transeptal puncture is going to happen. That's what we did it. So we are with the Safari right now there.
So is there a difference in the transeptal puncture in the TR versus TMVR? I think that's
yes.
we need to hear from you as well as from our echo chief.
Yeah, so it is usually, mid inferior septum for here, and we have to see it could be different based on the various patient, but if you see here, both echo and fluoroscopy have to match, if you can see that. Can you show the echo,
Yes.
where we did the transeptal? Go back.
No, it should be 4 centimeter, 3 centimeter,
Yeah, so-
anterior,
So,
posterior. Yeah.
no, the height we come later. First you have to make sure you're at the right spot.
Right.
Posterior, just about 4 is okay. For mitral clip, that also varies depending on the
explain.
size of the septum and all but as long as we are 4 or higher than 4, that's what matters, but more posterior for a mitral clip.
Yeah, the other thing, the minimum distance of mitral valve in valve, what they say is around 2.5 to 3 centimeters. The reason being, the balloon, when the SAPIEN inflates, has the balloon, outflow and inflow. You cannot have that balloon across the septum. There'll be a big problem. So that's why they recommend this. This don't have to be as far as mitral tear, but certainly you need a minimum distance for the balloon clearance. That's probably the most important aspect
35.
of this procedure.
So at
So
least 3
remote.
centimeter.
Yeah, about 3
so-
centimeters, I think it's a
So,
sweet
so
spot.
3.5 to 4
Yeah.
inferior posterior stick. You want to match on your fluoro landmarks for TMVR, valve in valve, and 4.5 to 5 centimeters depending on where you're doing your MTR.
Yeah.
Beautiful.
Now here, can you just show? We removed the where we entered with
Can we go live on fluoro,
yeah,
please?
fluoro.
Yeah.
Now you want to quickly go your steps now or want to later
Yeah, we are going to go through the steps.
on the slide?
So you can see Dr.
you have the
Kinney's,
slide there?
Yeah.
We have a
Put the
Gillis
steps
across.
there.
So wait 1 second. Go to the slide presentation again. So I think quickly go rapidly just off
What
fluoro.
is this? No, I need a 35 hour.
Take this. Take this. Take this.
It's a very small
Yeah.
valve,
Here.
the opening.
These are the steps of TMVR. AK.
Okay, good. So we exchange it to Agilus. Give me. So now we will go with the multi-purpose, and we will use. So if it is this is a stenotic valve, so multi-purpose is right there.
Take some flex off.
Okay, and then what we will also do is right there. Okay.
Stanley across the
We
valve.
use
Yeah.
And safari
straight.
wire.
No, straight wire. Usually,
Today,
35
Today.
J wire is okay if it is a regurgitation. But since it was stenotic,
Explain.
we
Long
went
J.
with the Terumo.
Some
straight.
ectopy from the catheter.
Pedro, you could see how we crossed, right?
Absolutely.
What's
Okay,
the title?
so now we
volume,
have a
Benji?
pigtail. Now we'll go with the 35 long wire and then exchange it to a long.
Take that, please. Take that.
This is a multi-purpose will come out. We'll go with the long pigtail and then we'll put a safari across. After that, we'll balloon dilate the septum
Full volume. Full volume.
with a 14 millimeter balloon. Then we'll dilate the prosthetic of the mitral valve.
Take that. Take that.
And after that, we do the fracture and then we will place the SAPIEN valve.
So all long catheters.
Is the steps okay?
Yep. They
Pedro, are you able to read that?
We
Yeah.
can see them, yeah.
Okay.
It's a little, it's too many.
Too small?
Small, but your summary is excellent.
Okay, let me change it.
Yeah, we can remove that steps now.
Very
So
nice.
remember the purpose of those are for people to have it in their armamentarium when they're doing the cases, and that's what our purpose of teaching with the CCC live.
But I think more
Absolutely.
important to mention to the audience that the picture has to
aortic
point
radius.
down.
Yes.
not up.
Very good.
So that's the mitral tricuspid down, aortic up. I think that's something that to remember, because that's how you create the trajectory on the position of the valve.
Yeah, SS, I think the steps are absolutely valuable for our audience to go into the step-by-step. Yeah.
Which one?
So you see the wire position, right? Pointing down
12,
instead
right?
of the aortic, which is pointing up.
Okay, let me take this out now.
1 second, AK.
Okay, good. Come on.
Hold the sheath, AK.
I have the sheath.
But you got hold the
You're
sheath.
on the lateral side.
He's holding the sheath.
Okay,
Give
I
us
have
the
the
balloon.
wire.
So now we took out the agilis. Now we'll go with the 14 millimeter balloon.
So let's show the audience that. Where's the?
Okay, you want to go in front or
No, I'll hold the sheath until you're ready, then you guys can go. So then I'll hold the wire. Let's just do it. Okay, you go. You go.
So this is a 14 Armada, right?
Yes.
And AK, what's the benefit of using this? Why do we need to do this?
So you're able to, more important, even if for the large
Stand with
valve to
ballooning the
traverse,
septum now?
yeah,
Oh,
to
the septum,
traverse
okay,
through
good.
the septum. So I think we're across, right?
Pull back
Yeah.
slightly.
You're too
You
far.
can see. Yeah. Actually, that's very
No, no,
nice.
it's not
That's
too
very
far.
nice.
Yeah,
That's
yeah,
the
yeah.
one, yep.
So it's RAO view, right? It's foreshortened.
That's okay. And leave it for a few seconds, right?
Yes.
So when you do this,
please.
Pedro, you'll also
This way.
see, look at the trajectory, how it is going.
Yep. it
It's a
goes
nice,
up.
nice parabolic curve. So we know the SAPIEN valve will go easily. Okay, now what we'll do is, this is another kind of a test we do, which is not fully deflated, half, and we are able to get through there. Yes.
Very good trajectory here.
Yeah.
Yeah.
Yeah,
Yes.
with- yeah,
you'll be
with bal-
hypertensive. You're ballooning the
Yeah,
valve.
with ballooning the septums, you got a little bit occlusive, okay? So now it's down.
You need one more or
Do
we're
one
good?
more. Yeah, I'll do one more.
Okay, get us the balloon for the,
So the reason for doing it twice is that these re-op
Recoil.
cases of recoil and fibrotic septum, especially if you read the operative note, if the surgeon goes through the transeptal approach through the septum, it's going to be a lot more fibrotic than the other, than let's say a direct atrial approach, left atrial approach.
Yeah, a lot of people actually suggest that once you inflate the balloon, leave it for 60 seconds. I mean, I don't think we do leave it for 60 seconds.
We
to open
usually
the
don't
transeptal.
assess. We do two inflations.
Yeah.
One going in, one coming out.
We've seen some transient hypotension with actually ballooning the septum. I don't know if it's the vagal thing or some kind of, but certainly it's, valve is ready? We'll check. Skirt this.
Okay, now time for valve fracture.
No, let's wait to come out.
I don't
Yeah,
have
maybe
wire.
Dr. Tan can expand a little bit of the benefits of the valve fracture,
Sure.
specifically
I
in
wire.
this case.
So we mentioned that this is a 25 surgical mitral valve. It's the smallest manufactured surgical valve in the market. So the true ID internal diameter is 23. And this patient has a very high BSA, over 2 point something.
Magan.
is the valve
yeah.
ready?
Valve is ready.
Yeah. And so we've believed that, an underexpanded 26 will be a problem for this patient, especially this is a
Will be very
first
hypotensive now.
transcatheter valve. Okay. And then, so we need to, we think that this will benefit the patient. We've done that for aortic.
Base 180.
Mitral is less.
Oh. Go.
Go. Done.
Good.
What
So
pressure?
it takes time. No.
And which balloon are we using here?
Okay, not
Okay,
going up.
26 true.
26 true.
26 through, okay.
It didn't do anything,
Okay,
right?
back up.
Back up.
Back up, back up.
But it
Wait,
didn't do
wait,
any
wait,
fracture.
wait. Yeah.
That's okay.
Get me another syringe.
Back
I
up.
think sometimes it's hard.
There's some
Okay.
VT.
Let it recover a little
Good.
bit.
Recover. Good.
I don't
Sometimes
think we
they
should
don't
try.
fracture.
No,
But
we
there's
need
no
to
waste
attack
on the balloon,
finish,
though.
no?
No, we did.
I think we got a good base.
No,
I think we
the
remodeled
question
it
is
nicely.
bigger balloon, no?
It's already 26. It's 2ID plus 3.
Is it stuck?
Okay.
Can do one more or no?
We're good?
Going to try once more, he's asking.
I think we should be okay. We're going to post-dilate anyways. So walk it out.
Is it coming?
Anyway,
No.
the echo can help us here.
Push it out.
I mean, it looks a bit bigger than
Yeah.
when we started.
Come out. Good.
One of the two that were not moving at all, one of the two leaflets start moving a little bit more. One is still stuck. So the area looks bigger than when we started.
Okay.
So
So it has done something.
yeah, we done something.
Well, we improved the prosthetic MS.
Yeah.
Right?
That's
The
Yeah.
question is that whether you have a QMR and the patient may not tolerate. So in this
Give
case,
me
looks
a
like the
bit.
patient actually quite well tolerated. And Stem show it very nicely now on the echo with color stem that the MR is not, torrential.
Yeah, it's not orange. It's about the same as when we started.
So that's something that to be mindful of, I think. If the patient has low EF, I'm not sure I can recommend this.
So one thing also I
Because-
noticed, once your
yeah.
pressure tracing is already at 22, 23,
Yeah, okay.
if it doesn't fracture, I don't think we should push too much.
Got it. So this is important now. If you have a camera, the commander system, the E faces down.
Yes.
Because aortic, it turns to the right of the patient, right shoulder. This goes to the left shoulder, right? Because the heart is the left, so you have to go opposite. Okay, let me just back in for you.
Good, stay there.
1 second, please.
Show me
Oops, sorry. Here you go.
Push the wire.
Yeah.
See, it's crossing over.
Okay.
Looks good.
Now
me
make sure
center
the
the screen. One
pacemaker,
moment, please. Let me
temporary
center
wire
the
is
screen.
okay.
Yeah,
Flex.
you're good.
You want to go in the low mag or?
Yeah, I will go into low mat.
Look at that. Look at
One
the
second.
pacemaker.
Go.
Okay,
It'll
now we are
straighten
good.
out. It'll
Yeah,
straighten
yeah.
out.
Beautiful.
A gentle pull on the wire usually
Yeah.
straightens it out. Go.
No, pacemaker wire.
Go. Try now.
No, wait.
Oh yeah, it's attached to the pacemaker.
Taking all the flex off here. And yeah,
There we go.
good.
Not a parallel.
Good. All right.
Okay.
Very nice.
Closing that.
Yeah.
Okay.
Okay.
Yeah, contrary to the tricuspid,
Go higher back.
Yeah, I am.
this issue with the pacemaker really doesn't
Yeah.
have any relevance here, correct?
No, we actually had a case that we dislodged the pacemaker about a
You wanna
few years
test the
ago
pacing first?
in a TMVR process, so it
Let
can
us-
happen.
Let us
Okay.
just place
But
it on.
usually not a problem, yes.
After that elegant discussion that we had with the tricuspid, very different issue.
Beautiful.
We just need 1 minute of focusing.
Yeah,
here.
please, everybody.
Pace 180.
You testing or?
Testing,
we're
testing. Did the
Okay.
pacemaker
Yeah,
move?
Pacemaker is
Back up.
Okay, back up. There's a little bit of pause there.
Yeah. Yeah, it's going. Good,
Okay.
good.
Yeah, okay,
Now?
pacemaker.
Now try.
Good,
Good.
Should we take it?
very
Not
good.
yet, not yet, not yet, not
Okay.
yet.
Off.
Off. Okay. Okay, 180. Hold on. So that thing has to be at the
We'll straighten it out.
Yeah, we're saying
Right?
that. Yeah, don't go too ventricular, right? Remember, that's the
180.
Yeah.
So the lower part of the sapien is at the lower part of the surgical valve. Okay, that's what we are going. Goal is okay as you're going up.
Push the wire slightly.
Yeah, I am.
Straighten it
Don't
out.
worry.
Good.
Okay, good.
Opening.
Good, perfect.
Okay.
Okay.
Keep pacing.
Back up.
Back up.
Back up. Good. Okay, stenosis is fully relieved.
Well, let's finish one more.
Yeah.
because it's
1 cc.
interplaying with the two pacemakers.
Can you give me one more cc?
But you want to get some more? Yeah, put
one more?
additional.
We already have 2 cc here. We want to add one more.
Yeah.
So Anu, to avoid embolization, is just perfect location the way you describe it?
Yeah. Okay, see here. I will go back here.
And slow inflation.
Yeah. See there?
Yeah.
I pulled back a little bit. The lower part of the SAPIEN valve should be at the lower part of the surgical valve. You see that?
Yeah,
That's
outflow
exactly
to
what you
outflow.
showed.
Yeah,
on the
outflow to outflow.
Outflow to outflow.
Like on the app that we showed in the presentation earlier.
Yeah. So that's how it is. So
Yeah.
I'm just holding there, and some movement, if at all any movement happens, then
The wire.
you got to do with the wire. You have to advance the wire a little bit. That's why the inflation was so slow.
Yeah.
Okay, go.
180.
Okay.
Not capturing.
Yeah, not capturing again.
Again.
Yeah.
That's
Yeah,
why
you
I
see-
remember I was saying that, the pacemaker is a...
There you go. Try
Okay,
again.
now?
There. Yeah. Try again, Fausto. Yep. Mm.
Okay.
Okay, now let me go
That's
further.
Probably, yeah. We don't see ectopy yet.
You need to inflate.
Probably,
Oh, it's there. Yeah, it's not through the tricuspid.
No?
Go up on the
Because
balloon.
that's the tricuspid ring. So you have to go into the.
Yeah, so much equipment there, right? You see a Swan-Ganz catheter, you have a prior pacemaker lead, you have the delivery system. So sometimes these can knock off the pacemaker leads and then, have to readjust.
Fluoro retry. Okay.
here we go now.
Also, patient with previous tricuspid repair is harder to cross
Yeah.
because it's a smaller orifice now.
Ventricle.
Once there, deflate the balloon now.
It's fully deflated.
No. He's
no,
talking
the
about
pacing
the pacer balloon.
Now I'm the balloon of the pacemaker.
Okay,
Once you're
the
at the
deflate.
ostium.
Okay, deflate now. No.
The
Go.
tricuspid ring. Yeah. No.
Okay.
The valve has become, pacemaker has become
deflate.
soft. You want to get a new pacemaker?
Maybe
should
this
be
will
okay.
make it.
Pull it back.
Okay. Now.
Pull it back more.
Okay, deflate.
And try now.
We probably
Balloon
lost
up.
its balloon up.
Get a new pacemaker, please.
Also, remember the commander system also in our way,
Yeah,
right?
of course.
So it makes it
You
harder
have a
now.
Swan, you
Yeah.
have a commander system,
So
you have a prior
a lot of
pacemaker
other
lead.
things to have to account for.
Syringe.
But echo-wise,
Yes.
how does it look?
I mean, the valve is, looks well opposed. You have a catheter through it. The MR is significant, but it's most
Yeah,
likely
that's the
because of the
catheter
catheter.
stamp.
Yeah, because of the catheter.
No paravalvular stent.
No PVL, no.
And why do we need the the Swan right now?
Yeah,
PA
that's
pressure was very high. We want to see if the.
Yeah, okay.
We want to.
PA
Very good
pressure is
question.
lower, yeah? Usually it comes down, it should come down because this is purely related to the stenosis, yeah. What's
try
the
the
PA?
balloon.
Yeah, put a
So
pressure.
PA pressure, anesthesia was a little concerned. PA pressure was 70 systolic. So
But now where is the we should have on?
once we deploy, once
No,
we
we
finish
don't
this,
have it. Yeah, we
PA pressure, you already
disconnected
have
it.
Swan, just put it on.
No,
Swan
we're
is-
not
Yeah.
connected. 1 second.
Yeah, because it will help to the passions of the pacer if we remove that Swan.
Okay, put the.
See below.
Okay.
There
yeah,
we go.
much better. Good.
That's it.
Yeah.
So remember, it was soft. Good.
Beauty.
Okay, good.
The
Okay.
longest part of the procedure, I guess.
Yeah, it's adjusting the pacer. Okay, good. Now let's make sure it's working.
Of course.
Connect the right pacer.
Okay, try now.
Hold it, Damien. Yeah.
Good. Keep holding. Yes.
Good. Pace 180.
180. Okay, good.
Yeah,
Give
there's
us another
still-
syringe.
Keep pacing, keep pacing.
Okay,
Back up now.
back up.
Take
Watch
this.
the waist, watch the waist. You have
Yeah.
the balloon.
Back up. And then,
Yeah.
can you do it, Gilbert? Can
Yeah,
you take
yeah.
this? Yeah. Good. Not
And to
here,
take out,
on the
let's see,
delivery
the
system.
gradient usually is less than 5.
Here you go.
Okay, good job.
3 to 4 is the usual.
Okay.
Push the wire.
Yeah.
Back out.
Give us a pigtail. The
Let's get
long
a pigtail.
And then we take this thing out. Okay, what is it looking like?
You got wire?
Yeah.
little, the MR is lower, no?
There's a wire across.
Yes,
the
there's a wire
yeah,
across
the
the
wire,
wire.
the
Let's just,
wire.
here you do it.
Okay.
Gradient is down to 4. So.
Pressure.
Under 4. Good.
Yeah.
So the PA pressure is still a little on the high side, but it's a little bit improved, 66 systolic versus almost 80 before in baseline.
Wow, that's a good improvement.
So
Yeah, no, these are not fixed pulmonary hypertension. The patient's RV was
course.
absolutely fine. So this is a reactive pulmonary hypertension and goes away once you relieve the MS.
Yeah.
Remember, it's one of the indications of MS management. High PA pressure.
Okay, now connect the.
all right, Stan, we only have a pigtail
Where's the swan?
across.
Oh, because you're
Yeah, the
basically.
gradient is
Next
4.
one is in the
Oh,
Oh,
okay, okay.
4 is good.
Yeah.
Yeah.
Very, very good.
Can we
Minimal,
connect the swan again?
minimal MR. Most likely.
Now, other question is, do you routinely have to check for the LVOT obstruction?
Well, that's a
Good
good
question.
question. So first thing is, if this patient is hypotensive, right, and
Give
no
me a
effusion, that would be the first
crossing wire
concern,
and-
Okay.
right? So I think that's one thing. And second, if that's the case, you have to quickly cross the aortic valve, so you may have provide some support. That's what we do. We used to actually put a pigtail into the LV from the aortic side, and you can exchange it to a mechanic like an impeller or something like that to help provide flow. Especially, but there's really no other issue, other
What are you trying to do
mitigation strategy. You have to
Correct
plan it
LV
ahead of time. If you're
gradient.
concerned, you have to do leaflet modification.
You want it?
Or alcohol septal ablation if you the patient has a
Take
thick
your
enough
one.
septum for that. We have done that as well. That we do septal
Okay, do
ablation.
it.
In fact, all the current TMVR trial, if the anatomy is favorable for the valve, but not the LVOT, we actually recommend alcohol septal ablation first, and then wait 6 to 8 weeks, and then repeat the scan. And we have seen some success of actually improving the outflow tract to allow the patient to screen into the trial or able to undergo the valve in valve.
So PA pressures were 80 when we started. It's
Yes.
now 62.
That's right.
Systolic.
What about the LA pressure? We have it?
We are going to give you all
LA
the pressure.
we're going to give you.
Three.
We're going to cross the valve again. So why you have the you have a LVOT gradient now?
No, 3. Minimal MR. Mean gradient of 3 through the mitral valve.
Okay.
No.
Can you imagine?
Yeah, let's measure there. Put the continuous Doppler there. Yeah, take that. Take that. Get ready.
Should be RAO,
No, they're crossing
prosthetic valve.
Crossing is okay.
Anu, do you want to put a wire to straight that pigtail when you remove it, or you just do it?
Oh, that one we will.
Yeah, we'll
I mean,
do
you
it
can do.
exchange J. Exchange
We
J.
need a straight J.
Yeah,
Yeah.
Yeah,
put it
through
there.
across the septum.
Yeah, yeah.
Yes.
exactly.
Put it to yours. Yeah, 11 and 5. 11 peak gradient through the LVOT, 5 mean. Here, take that.
Thank you, Stan.
Yeah.
Okay,
Excellent.
now we're going to measure some LV, LA direct gradients.
Beautiful.
let's-
Let's do 50 scale.
So this will put everything to rest. True old school hemodynamics.
Yeah, 22, 11. Yeah.
Zero everything, please.
You take that. Yeah.
Can you show the previous
Look, good,
tracing?
Good. Go to pressure. Good.
Show the previous tracing. So completely obliterated the gradients here.
Yep.
Yeah, but the EDP is high, no?
No, it's the 10, 12.
10?
12.
Okay.
Yeah,
Yeah.
Okay.
Good.
that's within normal range. Yeah.
And,
LVAO. Now see the LVAO now.
LVAO.
Go to 200 scale.
No, can you go to both high?
Yeah, the LV
50, 50, 50.
I mean, AO tracing.
AO will have to pull back.
Right.
Not 200, 50.
Okay. Okay.
You really want it, or?
That's fine. Leave it.
Amazing, man. Amazing.
Good. Let's come
Okay.
out. Okay.
Hold on. 50 scale.
5 to 3. 5 to 3.
VVS are still high. And go fast speed.
Yeah, so there's some diastolic compliance issue also,
Of
right?
the
These
LA.
long-standing patients with the long-standing MS.
And diastole is okay, maybe 2 or 3, right? Gradient.
I don't think there is any
That's a
gradient or regurgitation now.
Correct. And
All physiological now.
you have a previous tracing. Can we show the previous tracing also? Can see significant gradient, which is
Yeah.
now abolished.
Yeah, if
Can
we
we
don't have
zoom on?
if we don't have MR on the echo, this is all, the diastolic dysfunction.
No MR at all. No
For the
MR
V
at all.
wave, yeah.
Show to SS.
Camera, this one.
No MR, so we're
No
good.
MR. No MR at all.
This one was before.
This was pre.
That's the septum, yeah.
Good. And print the latest one also. Yeah, keep it there. Good. Okay. How are we now? What's the next step now?
Closure.
Nothing, we are going to take out that pigtail
Minimum,
using a J wire.
Minimum.
Yeah.
Minimum.
But you're already in the LA.
Yeah,
LA,
LA,
from
yeah.
LA through
Minimum
the
central,
septum.
yeah.
The question is indication for ASD closure.
No indication SS here. I think we would just remove it. 90% of them heal in 30 days. Unless there's bidirectional shunting with significant hypoxemia, you almost never do it.
Show us a septum now.
Echo. Left to
Yeah,
right. Left
echo.
to right.
Go to 200 scale. We are pulling back the LV.
Color. Yeah, explain color.
No
This time you
gradient.
don't see much. Okay.
Yeah, nothing.
The,
You
the
don't see.
septum is not bad, no?
Yeah, it's 5 by 3. 5 by 3 millimeters. Left to right. Not even a puff of right to left.
Yeah, it's a small ASD. That should heal up.
Okay. So what will be the indication of ASD closure in these kind of patients? I
Yeah,
know
so-
we used to do quite a bit. Now we have almost stopped it. So what are the indication will be?
Yeah, so profound hypoxemia, or if you have significant bidirectional shunting. Outside of that, you rarely do it.
Okay.
Or if patient has, in this patient, if the pulmonary hypertension continues to worsen, we'll reassess in 30 days, and we think it's because of significant left to right shunting, then we may end up closing it.
Presence of severe TR also, right?
Okay.
And right to left
Okay.
shunt.
What's the next step now? What are you doing
Just
now?
closing the groin.
Closing. Start.
Let's
yeah,
give 30
lecture.
protamine, please.
Okay. Yeah, put the lights on now. So let's go to our, so overall, Pedro, the case has been done masterfully with excellent results, excellent hemodynamics and echocardiographic dynamics. Angiography, usually we don't do any LV gram, but we saw the hemodynamic, no gradient, and valve looking good, functioning good. And let's go through some of the presentation of the TMVR field. Let's go to the slides, please.
Next slide.
40.
Check what's
Yeah.
happening in room 214.
So we'll talk about some of the recent publication in the TMVR and MTR field. One is the update in the TMVR, various devices. Then Apollo trial, 2-year data. Transapical TMVR, if you have failed TR, what can you do? Then antithrombotic therapy post-TMVR and the mitral valve interventions in USA in the elderly patients. So this is basically nice review article in circulation cardiovascular intervention in the TMVR for the treatment of mitral regurg. So we know where does it fit in. Moderate MR, no early intervention compared to moderate AS. Unload trial showed early intervention, but not for the mitral. Mitral has to be moderate to, although Matterhorn trial did show moderate to severe MR, functional, little better with the TR. So anyway, we have secondary MR, who is a high surgical risk. If not, patient going for cabbage, then you do surgery at that time. If not, those patients are high surgical at present, being treated with transcatheter valve. So classical is the TR has been shown very effective, decrease mortality and heart failure readmission, and therefore first step should be TR. If patient is not a TR candidate, then you get to the TMVR. as you can see there. So this is basically and there's a nice algorithm which has been shown here with the multiple steps. So we try to do, okay, slides are off somehow. Yeah, okay. So TMVR has the advantage, total abolition of the MR, but biggest problem is very selected cases, high screen failure. And of course, risk of, we've spoken about LVOT obstruction, valve embolization, anticoagulation, and so on and so forth. But TEER, incomplete MR reduction, and of course, it's operator dependent. But key is that if you do, it is a very safe long-term procedure. So that is the key. And of course, the question remains is the leaflet detachment and a lot of limitations for the TEER. So these are the various devices which are in the process, which some are being done, some are in the future, how they are going to look into it. And what really is so far is we have the Tendyne, Intrepid, and M-valve, SAPIEN M3. Those are the one really has gone to the various trial devices and small number. You see that these trials have been going on for last 10 years. It's still very small number of cases which are being used for these valves. So one of them is SAPIEN M3. Looks very promising, two-step. First you do the dock and then you put a valve inside. Very effective. And of course, it will take probably few, maybe still 1+ year. So I think likely is that early 2026, because data have been very promising. It get approval. We are expecting in first, second quarter of next year. And this is a nice design of this valve. Second is the Alta valve, and that basically is the whole cage into the atrium, and then you put a valve from inside. So this is also going through the various trial phases, and then high life system TMVR, which is first the ring, and not uncommon that the mitral valve, the one which is going to work is you have two-step. One, first stabilize the ring, and then you put the valve inside. And that actually has been the case. And then, of course, we know the Tendyne, which got approved May this year, particularly patient with MAC. So MAC patient, that's what the approval is clearly for the MAC. High-risk cases, Tendyne is available. We have not used any. Gilbert, any plan for any good MAC case if it cannot be the Apollo case?
No, they barely launched the US. They've done nothing. Yeah, because it's transapical is the big problem.
But my question is, if we have a MAC case and suitable, we can put in the Intrepid trial, Apollo trial, right?
Correct. Yes, that's right. Yeah, and if it's not, we can try commercial Tendyne, but usually they probably more challenging. So.
And not only that, it's a transapical.
Yes.
So we have the going away from the transapical completely, and this is the 1 year data which we presented last year in terms of very good, as you can see, mortality was 0% in house, 6.7 at 1 year, and mitral regurgitation all disappear. You see that none to trace, only or maximum mild, maybe 3-4%. So kind of a very effective decrease in heart failure. And Gilbert presented the 2-year outcome of these 33 patients in the New York valve. And now with the second generation, we actually are part of the trial. We have done some cases, and we have one case scheduled for end of the month. Right?
Yeah, that's the new 29 French system.
And now the 29 French system. The problem is the very strict criteria. Enrollment. You even think about that you had 10 cases, they probably get approved 1 or 2. So what can be done? I mean, if they become so restricted, so even if get approved, what good it will be for common usage?
It's the problem with mitral valve space. That's the biggest problem. And that's why you see all the numbers in the studies you've shown are barely touching 2 digits. So screen fail, because no one wants to fail in the study. Everyone who's investing in these companies or in these devices don't want to fail. So they're very selective in who they want to do. So it's no longer compassionate. These are feasibility studies.
Yeah, so 42 and 48 millimeters, of course, the question is that how with a 29 French device you can do, because the vascular complication has been issue. And then, of course, there was some mortality. The key is the mortality occurred is not because of the device failure. That's the key. It is because of their heart failure, further heart failure related death. which cause, not the device. Very important that device, once it is done, initial success, out of the hospital, the device does not give trouble, although some cases of valve thrombosis has occurred, which occurred in any of the TMVR valve, but no embolization, and these patients do from their background disease process, as the regurgitation, as you can see, persistently, almost gone. Mitral regurgitation is very little in these cases, and so clearly, then question comes that what if you have a tear, and then you need to do, patient is a non-surgical, very high surgical risk. Patient cannot go for surgery. So, we come up with some kind of a crazy approach. So this is a tear failure. See what happened? Elastic clip basically is like an electric cautery that you go through, and then you lacerate the intermitral leaflet, and then put a self-expanding valve. And this is some special technical self-expanding valve, has shown a good results. But yes, the M-tear failure, just like a tower failure, they go for surgery if they're appropriate. But many of these cases are very high risk. Surgeons will not touch it because of the high comorbid condition. But we have one strategy of elastic clip and the transapical, but again, transapical TMVR. So then question comes is that it can be done in selected patients, and so then anti-thrombotic therapy, which I emphasize repeatedly, that many of the small studies have done, and basically showed the clinical or subclinical valve thrombosis occurs, whether it's a whether it's a surgical valve or it's a percutaneous valve. So key is that 47 studies with the 6,000 plus patients with a long-term follow-up showed that bioprosthetic mitral valve thrombosis occurs in 5% per 100 patient years. So clearly that valve thrombosis is a factor. And now maybe in the latest data will be less, because what we found, it occurs the early versus late. Happen first 90 days. Second, more subclinical. Third, much higher with the TMVR compared to surgical valve, 7 times higher with the TMVR compared to surgical. Then oral anticoagulation versus no anticoagulation, tremendous, very high incidence of valve thrombosis if you're not on anticoagulation. And within the anticoagulation, vitamin K antagonist, which is Warfarin, is superior compared to direct anticoagulation. So key is NOAC, DOAC are not recommended, but many times we use it. But key is the real data are from the vitamin K antagonist on these cases. So therefore, it's not uncommon with the bioprosthetic mitral valve thrombosis, not uncommon with numerically higher incidence in transcatheter compared to surgical valve, but the comparison was not necessarily significant. And vitamin K antagonist associated with a lower incidence of valve thrombosis compared to direct anticoagulation. So this is actually another paper putting all these things together. So last one is very important, that elderly patients, what to do, what is going on, what is the trend in United States for the late outcome in patients with the elderly patients with the mitral valve disease. As you can see, the graph in the center, if you can see there, surgical numbers are going down and your tear numbers going up. And of course, the TMVR gradually going up. Very small number of TMVR cases. So key is that more patients are getting treatment for this end stage or elderly patients getting the mitral disease. And surgical intervention actually is going down, but it is the transcatheter intervention which is going up. 94.8% increase in index transcatheter intervention, while there is a 15% decrease in the surgical. Now, at any level, whether you have surgery, MTR or TMVR, the outcome is dependent on the patient frailty. Patient is very too frail, very high. So various degrees of low frailty, intermediate and high, there is a frailty score from 1 to 10. So based on that, higher the frailty, higher is the mortality in these patients. So just think about the patients who are the high frailty. In those cases, 57% mortality of the surgery, 74% in the TR, and 81% in the TMVR. So very important, and these are basically showing that various outcomes of these valves. Now, our other problems do occur because these are the elderly patients. So basically, conclusion was the mitral valve intervention in elderly patients are increasing over time, driven by transcatheter therapies. 5-year mortality varied by type of intervention and was significantly influenced by the frailty and social vulnerability. So patients who are physically, comorbid condition. So basically, just to put it together, the TMVR devices continue to evolve over the last 15 years, but still don't have a good one. Yet will take probably a few more years before we have. The small early feasibility study of 33 patients with the Intrepid TMVR, transfemoral, transseptal showed good. Of course, there is mortality will occur in these patients, but not device related, and very effective in eliminating the mitral regurgitation. And then meta-analysis of the antithrombotic therapy post-TMVR strongly support the use of vitamin K antagonist over DOACs and NOACs and over DAPT, and should be the preferred treatment. In this patient is already on Warfarin. And then the mitral valve intervention in elderly patients increasing over time, and it's dependent on the mortality is patient's frailty and so. So 3 questions. Following statement is not true about the results of the 2-year outcomes of the transfemoral TMVR using Intrepid device. Complete resolution of MR in the majority. Majority of the death occurs due to device related. Bleeding and vascular complications still remain major obstacle, and mitral valve gradient remains very low. So wrong answer is B. The death does not occur because device related. It is the natural disease process, and vascular complications are going down with the 29 French compared to the 40 French venous device which you used to have. Second, the trial comparing various antithrombotic therapies and valve thrombosis post-TMVR revealed the following except subclinical valve thrombosis occurs more common. OX has lower valve thrombosis, oral anticoagulation compared to no anticoagulation. TMVR has similar valve thrombosis as surgical valve, and vitamin K antagonist has lower valve thrombosis than direct oral anticoagulation. Answer is C is wrong, because TMVR has a much higher valve thrombosis compared to surgical valve. Lastly, the ongoing trends in the management of the mitral valve disease in the elderly in the USA is true, except there is increase in overall mitral valve intervention. There is an overall increase in index surgical interventions, marked increase in transcatheter intervention, and MTR has the lowest in-hospital mortality. The wrong answer here is B. There is an overall increase in index surgical intervention. No, it is all the transcatheter which are providing care for these elderly patients. Many of them are non-surgical. With that note, I complete my presentation. And so.
Very good, very good. So thank you very much for the heart team approach, the beautiful case. And remember, this case, as well as all the others, will be archived this afternoon at ccclivecases.org. Now, our structural heart cases are every month on the second Tuesday at 9 a.m. Eastern Time. The next one will be November 11, 9 a.m. See you then. Thank you so much.
Thank you.